Hello and welcome. Thank you everyone for joining us today. My name is Aaliyah Poulos and I work at the University of Chicago Comprehensive Cancer Center's Office of Community Engagement and Cancer Health Equity. Our job at the Office of Community Engagement is to bring cancer research, the cancer research of the University of Chicago to the communities we serve, which is why we are so pleased to have Dr. Gupta with us today to talk about colorectal cancer in recognition of March, which is Colorectal Cancer Awareness Month. Dr. Nina Gupta is a faculty physician in gastroenterology at the University of Chicago Medical Center, and she is also a member of the Cancer Risk and Prevention team. Thank you so much for joining us today, Dr. Gupta.
Thank you so much for having me.
So my first question for you is to just give us a little colorectal cancer 101. What is colon and rectal cancer and how does it develop?
Sure. So colon cancer basically refers to a cancer that originates in the colon, which is also known as the large intestine. And if this cancer originates specifically in the last part of the colon, which is called the rectum, then it's called rectal cancer. And part of the reason that colon cancer is so important to understand is because colorectal cancer is actually the second highest leading cause of cancer death in the United States. And it's actually a cancer that we consider to be highly preventable. So what I mean by that is that in most cases of colon cancer, the cancer starts from a precancerous growth in the colon called a polyp. And with screening, we can actually find these polyps before they ever turn into cancer and remove them right then and there. So this is part of the reason that we consider this to be really a preventable type of cancer.
So are there symptoms of colorectal cancer, and what should people look out for if they're trying to monitor their own health?
Absolutely. So there can be some symptoms, and with colon cancer, there can be symptoms which can occur with generally any type of cancer, and then there can also be some symptoms which are specific to the GI tract. So whenever the body develops a cancer, the body's metabolism is having to really rev up and work really hard to support the growth of those abnormal cells. And that process can cause symptoms like unintentional weight loss or having really profound fatigue that's out of the ordinary for someone. But some of the more GI specific symptoms with colon cancer can include seeing blood in the stool or having a really significant change in a person's bowel habits. So these are things that I definitely recommend people bring up with their doctors if they start to experience. Also, if patient's doctor finds that they are anemic when they do blood work, meaning that they have low blood counts, this is another sign that can prompt an evaluation for colorectal cancer.
Okay. And so what are some risk factors of colorectal cancer? And are there any steps that people can take to reduce their risk of colorectal cancer?
Absolutely. So when we think about the risk factors for colon cancer, we really divide them into two main groups. The first are non-modifiable risk factors. Those are things that people really can't change about themselves, but then there are some modifiable risk factors as well. So with colon cancer, the number one risk is actually age. So that's part of the reason that colon cancer screening is recommended for everybody in the general population once they reach a certain age. Another main risk factor for colon cancer is having a personal history of colon polyps. So for people that have a colonoscopy and are found to have colon polyps, they're recommended to keep having colonoscopies at certain intervals going forward in their life. There are other non-modifiable risk factors. Those include things like being male and being African American. African American men actually have the highest incidence of colon cancer out of anybody in the United States. And African American men are also more likely to develop colon cancer at a slightly younger age, so in age less than 50. In addition to that, there are certain GI conditions which can increase the risk of colon cancer. So those include things like inflammatory bowel disease, which encompasses Crohn's and ulcerative colitis. So patients who have those conditions are recommended to have regular colonoscopies at certain intervals. And then lastly, what I'll mention in terms of the non-modifiable risk factors is that having a family history of colon cancer can actually increase a person's risk of getting colon cancer. So when we think about the family history, the amount that a person's risk is increased really depends on how many family members they've had affected by colon cancer, how close those family members were. So whether they were immediate family members, what we call first-degree relatives, those are parents, siblings, and children, or if they were more distant relatives. And then also what age those family members were diagnosed, whether it was at what we consider a slightly younger age, which is less than 60, or at an older age. But for anybody that has a family history of colon cancer or several other cancers in the family, we really recommend talking to your doctor and bringing this up, because sometimes there can be a mutation that's being passed down in the family that's contributing to that increased risk. And for some individuals, it may be the right choice for them to have genetic testing, which can help to identify if one of those mutations is present. And if it is, oftentimes there are specific personalized screening recommendations for that individual going forward, and also for their family members. And then I also mentioned that there were some modifiable risk factors, so things that we feel like we can take control of and do something about. And those kind of risk factors include obesity, smoking, and eating a highly processed diet. So certainly if someone is a smoker, quitting, and anybody maintaining a healthy weight through regular exercise and a healthy high fiber diet can help to reduce their risk of both colon polyps and colon cancer going forward.
Great, it's a lot of great information, thank you. Switching over to screening, what are the different types of screenings that are available for colon cancer?
So there are a few different types of screening available. The main first line recommended screening for colon cancer is a procedure called a colonoscopy. So in this procedure, a patient has to drink a bowel preparation that cleans out their colon completely. And then they have a doctor do a procedure where they use a long flexible tube with a light in the camera at the end to look directly inside the colon and look for those precancerous growths, those polyps that I mentioned. And if they are found, they can be removed right then and there. So this is one of the big advantages of using colonoscopy as the first line screening method. And those precancerous growths are actually fairly common. They occur in about 30% of men and 20% of women, which is why part of the reason that colonoscopy is recommended as the first line screening method for anybody that can undergo the procedure. Now, there are some other options for screening for colon cancer. Those include things like stool-based tests. So in particular, there's a test called a FIT test, and then also another test called a Cologuard test. Now, the FIT test is looking for microscopic blood in the stool, and the Cologuard test is looking for microscopic blood along with some DNA markers. So these tests do need to be done a little bit more frequently than colonoscopies, though they can be done in a patient's home. They don't require a prep. They can be done just with the stool test, with the stool sample and the test kit. But if a test is negative, for example, a FIT test is negative for a patient, they're going to need to repeat that every year. And if the Cologuard test is negative, they're going to need to repeat it every 3 years. However, what's really important for patients to understand is that if either of those tests is positive, they are still going to need a colonoscopy. The next step is for them to have a colonoscopy, because that's the only way that we can directly look for those polyps and growths. And then I'll just very briefly mention that in some centers, there's another type of test that can be recommended for screening called the CT colonography. And that is a test which also requires a bowel prep, but instead of having a procedure, the patient has a very special type of CT scan to look for any large polyps. And that really needs to be done under the direction of a radiologist who is specialized in reading those CT scans.
Okay. I've heard colonoscopy referred to as the gold standard of colorectal cancer screening. Is that something that you'd agree with, that that's, you know, the best method usually if you're able to get one?
I would absolutely agree with that. You know, for everybody that in terms of their general health and the other medical conditions they have, if they are able to undergo the procedure, we do recommend that as the first line procedure. Again, because it has these two functions. It's not only diagnostic, but it can be therapeutic, meaning that any polyps that are found can be removed right then and there. And that's not even something that the patient feels during the procedure.
Great, good to know. So who should get screened and what is the recommended starting age for screening?
Sure. So colon cancer screening is recommended for the general population, for everybody in the general population once they reach a certain age. And the current recommendation is for everybody if they're what we call average risk, meaning they don't have a family history and things like that. They should start at age 45. So previously, people may have heard that it was age 50. But as of some newer recommendations and guidelines that have come out recently, that's been lowered slightly to 45. And that's been driven largely by an increasing rate of colon cancer in slightly younger individuals, people that are less than 50. And so that's part of the reason for that recommendation. But again, with all of that being said, people that have certain GI conditions such as inflammatory bowel disease or people who have a family history of colon cancer may need to start earlier. And to give just a quick example of that, if someone has an immediate family member that's had colon cancer, that includes parents, siblings, they should start at age 40 or 10 years before their family member was diagnosed, whichever of those is sooner.
Great. So just reminding us how important it is to know your family history and be having these conversations with your doctor.
Definitely.
So in a lot of different cancers, we see disparities along racial and ethnic lines and socioeconomic lines. Do you see disparities in incidence or mortality rates of colon cancer?
We do, unfortunately. And this is something that the GI community is really actively trying to address and a gap that we're trying to bridge in every way that we can. So we do know that African Americans have the highest incidence of colon cancer and also the highest mortality from colon cancer out of all of the ethnic groups in the United States. To give you an example, their risk is 20% higher than for white Americans. And unfortunately, African American and Latinx communities have some of the lowest colon cancer screening rates in the country. We do also know that low socioeconomic status is independently associated with a higher risk of colon cancer.
Do you see barriers to colorectal cancer screening for certain groups or treatment?
We do. So there can be many barriers to colon cancer screening in certain groups. Some that we've seen include just a general lack of knowledge about colon cancer and colon cancer screening. Sometimes in certain cases, there's a mistrust of the medical system. And then a barrier can also be lack of insurance to get things like any of the screening tests covered, particularly colonoscopy. And even in cases I've seen where those hoops are jumped through and all of those barriers are crossed and the test is finally scheduled and someone is getting ready for their colonoscopy, there can be some other barriers to actually getting it done. Those can include not being able to take a day off of work for a procedure for a lot of people who really need to be at work every day, or even people that have trouble getting transportation to and from a procedure. So these are all some logistical barriers that we need to think about as well. Another barrier can include misunderstanding or misinformation about the process, the procedure, and the prep. And an example of that I've come across is that in some doctors' offices, the preparation instructions for the colonoscopy and the bowel prep are only available in English. And this can be a barrier for people that are not native English speakers. And to get a successful screening colonoscopy, it's really important that the preparation is done right so the endoscopist can see everything that they need to and do a thorough exam. So I really encourage everybody, if they're in a situation where they're being scheduled for a test and they're being given instructions, that they ask as many questions as they need to, and they make sure that their preparation materials are given to them in a way that they can understand and is very clear for them.
Wow, that's really interesting.
I'll also mention that another barrier to colon cancer screening that in my opinion, that I see is that oftentimes colonoscopy is presented as the only option for colon cancer screening. And we have talked about all of the benefits of doing a colonoscopy, but I think that if we want to really increase screening on a national level and get screening rates up, we need to make sure that patients are able to have an honest discussion with their doctor about what all of the different types of options are. Because we definitely feel that in GI, the best screening test is the one that actually gets done. So we need to keep that in mind. And really briefly, just putting my cancer risk hat back on for a second, I'll also mention that one of the barriers I feel to timely and appropriate cancer risk assessment in individuals and giving them their personalized recommendations is that in a lot of cultures and for a lot of people, it's very taboo to talk about things related to the bowels and the GI tract and having colon polyps or going for a colonoscopy. So I really encourage people to talk openly with their families about these types of things and ask those questions, because at the end of the day, it affects everybody's health and what steps they need to take for their health going forward.
That's really true. That's great advice. Um, what can grassroots community organizations and patient advocates do to reduce some of those barriers that you had mentioned?
So I think one of the biggest things that advocacy groups and community organizations can do is really get the word out that colon cancer should be thought of as a preventable cancer, and that screening is recommended for the entire population once they reach a certain age. So they can help share information about the different options for screening for colon cancer. And they can also have individuals share their experiences having things like a colonoscopy, because I think there's a lot of misunderstanding and misconceptions about the process. For example, things like our bowel preps have gotten better and better. They're more and more palatable. They're not as uncomfortable for people to go through. The procedure itself is usually quite short. Sometimes people don't realize that it's normally less than 30 minutes. And it's really a procedure that shouldn't cause any discomfort. So I think that groups helping to have people share their stories and get the word out about different options for screening is something that can really help us move the needle on national screening rates for colon cancer.
Yeah, I agree. Some personal stories can really have an effect on whether or not people are willing to take those steps. So it can
Exactly.
be really powerful. Um, so do you have any final words for our viewers, or one key takeaway from today that you'd like to leave people with?
I do, and it's hard to boil it down to one. So I would say three main things that I think are really important for people to know. The first is, don't be at all afraid to talk to your doctor about your bowels and your GI habits. The next that would be that when colon cancer screening comes up, make sure that you have an open, honest discussion with your doctor about all of the options and what will be right for you. And the last is to talk to your family openly and talk specifically about family history. Because really, things like family cancer history are not the types of secrets that should be kept in families. Again, it affects everybody's health going forward, and we should be able to have those discussions.
That is great advice. Thank you so much for joining us today, Dr. Gupta. We really appreciate you sharing your expertise and taking time out of your day to talk with us today. Thank you everyone who has watched this video. We hope that you've learned some great information about colorectal cancer. One other question I wanted to ask, are there any, if we were to point someone toward an online resource or somewhere where they can find out more information about colorectal cancer, is there any resource that you recommend?
Yeah, absolutely. So our website, the University of Chicago section of digestive diseases websites has a lot of those resources. So for anyone, if they just kind of type that into Google, they should be able to get to our main website and then be directed to a lot of those resources. And I will also mention that our preps for the colonoscopy and the instructions, because a lot of times people want to know what that's all about, those are all available online as well as PDF files.
Great, and we'll include that link in our description here when we post this video. So thank you again for joining us today, Dr. Gupta, and have a great rest of your day.
Thank you, you too.